This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I am one of the course directors for Critical Care Academy. I would like to introduce our speaker, Dr. David Weissman, who will be providing an overview of the underlying principles of ultrasonography.
As we know, the physical exam is notoriously insensitive for physical exam features. If a physical exam feature is present, it has a wonderful specificity. Unfortunately, the sensitivity of the physical exam is very poor. This is the advantage of point-of-care ultrasound. And to display that advantage, this is comparing the sensitivity of point-of-care ultrasound versus chest X-ray for various issues, including pleural effusion, CHF, pneumothorax, and pericardial effusion, and across the board, the sensitivity of ultrasound outperforms that of chest X-ray. As I've alluded to earlier during the beginning of this lecture, ultrasound is a skill that does require some refinement. Basic knowledge is important, which we'll be discussing during this lecture series, including some basic image interpretation. However, image acquisition and clinical integration requires ongoing use and support, working with experts in the field, as well as taking many workshops that are available throughout the country to build one's skills. A little bit behind the physics of ultrasound, the probes that are used in ultrasound produce sound waves that travel through various mediums, whether air or parts of the body. A hertz is defined by 1 cycle per second of sound waves. In medical technology terms, the probes will produce sound waves between 2 to 10 megahertz. Pictured here are our 3 commonly used probes that we use in point-of-care ultrasound. To our left is the high-frequency linear probe. In the middle is our low-frequency curved probe. And to our right is the low-frequency phased probe. These 3 probes all have different characteristics, which we'll speak about momentarily. But first, a little bit about the physics behind how the probes work. As electrical signals come down the probe, there is typically lead-based crystals at the end of the probe that have piezoelectric properties. They create the electrical energy into mechanical energy we call sound waves traveling through tissues. However, for every second in time, 9/10 of that second, they are actually waiting for the sound waves to return, at which point they'll change the mechanical energy back into electrical energy, sending that information back to the computer, which will create the image. These probes are different in characteristics. The high-frequency probe is wonderful to delineate different structures. However, high-frequency probes are subject to attenuation. That means the sound waves, unfortunately, do not travel very deeply. We can get about 5 to 6 centimeters deep using a linear high-frequency probe, but this is great for superficial structures, especially when we're doing our ICU procedures. The curved probe is a favorite of our emergency room physicians because it has a large foot base where you can have a large viewing screen available. With the low frequency probe, because the sound waves are low frequency, we can penetrate deep into tissues. So we can get quite deep, down in the order of 24, 26 centimeters deep. The phased array probe is our most commonly used probe. We tend to use in internal medicine primarily because of the small footprint here, which will help us to get in between the ribs so we can access the heart. It can be quite intimidating when first starting to use ultrasound is all the buttons that are present on a typical ultrasound machine. And I always say that the ultrasound machines of today are extremely smart and they help us out quite a bit. In fact, you can set to the machine whatever structure you will be imaging, such as the heart or abdomen or a superficial structure. And by doing so, the machine sets a lot of things for us that we don't have to worry about. It will set the depth for us. It will set the frequency for us. It'll set the gain for us that are typically seen for an average patient, and that is extremely helpful. It'll also set the computer marker on the right side, which we'll get to a little later. So the only 2 buttons that users should have to really know how to manipulate are the gain and the depth. and we're going to show you some examples here. So looking at our depth example here, we have 3 images, 1, 2, 3, and this is a parasternal long axis of the heart. You can see image A has quite a bit of depth. This is going down to 23 centimeters. By going down this deep, we have quite a bit of screen real estate that we're not using. And by having a lot of screen real estate that we are not using, our quality of the image, the foreground pictures, are not as crisp. So we try to avoid too much depth because that may affect the crispness of our image in the more closer fields. If we move to panel C here, this is at 11 centimeters, and you can see here we're kind of cutting off the heart just at the pericardium just about, and the inferior lateral wall, and this is obviously too shallow. So the optimal depth for this particular patient is 15 centimeters, and here we can see the entire heart in its entirety, and a very important landmark would be our descending aorta pictured here in the center of the screen. So that is the optimal depth for this particular patient. Going down to the lower panel, give us an example of what gain does. So consider gain like a brightness, and it increases the brightness on the screen. I find a lot of novice users want to increase gain right away to help enhance the image. And I would caution new users to doing that. By increasing the gain, you will increase the brightness and you will increase the whiteness of the entire picture. So things that should be more gray in tone or dark in tone will appear more brighter. And that may lead to misinterpretations of your image. So I would caution against overgaining, especially for new users until you are used to looking at images. In this slide, we are going to be introduced to the computer marker. So every probe has a marker, and we'll go through how do you identify the marker on the probe. And then there's a computer marker. And these two markers have to be in concert with each other. And one very important component of ultrasound is orientation. So briefly, you can see here there is a computer marker on each one of these images. This is a shallow image, imaging the thyroid pictured here. And the computer marker is on the left side of the screen. And this is a coronal shot through the abdomen. We're looking at liver, we're looking at kidney here. And you will also notice the computer marker is also on the left side of the screen. And this is called the traditional radiology computer marker point. In traditional radiology view, all computer markers are on the left side of the screen. So that way we can tell which is north. The patient's head would be listed here, and the patient's feet will be going down this way. And this is for a coronal shot, and we'll go through several examples of how we know the patient's orientation on the table by the way the probe marker is situated and the computer marker is situated. And everything kind of gets blown up in echocardiography world. In echo world, because our friendly cardiologists created echocardiography, they chose to place the computer marker on the right side of the screen. So everything in echo world, for the most part, typically done throughout the world, will be on the right side of the screen. We'll talk more about orientation in echocardiography in our next session. Now we're going to talk about how to make our ultrasound imaging of high quality. There are several issues with losing the quality of the sound waves, and it is the importance of obtaining high quality sound waves returning back to the probe, where the probe will then convert that sound wave back to electrical energy and back to the computer. The more sound waves we are able to get back into the probe will improve the quality of the image. So there are several factors which do play a big role in obtaining those sound waves. Most get lost. So to help control those sound waves, one of the important concepts is acoustic impedance. And acoustic impedance has to do with the differentiation between various materials, especially air and skin. So there is a large acoustic impedance between air and skin. And to cut that down, we have to use our friend gel. Gel drastically reduces the acoustic impedance, thereby allowing our sound waves to travel freely through the skin and into the structures below. Likewise, we have to think about what we're imaging below the skin. Pictured here, we have sound waves hitting a target that is at an angle, and you can see our probe is also held at that angle. Again, we are trying to think about what we are imaging below the surface to enhance the ultrasound beams coming back to our probe. The more ultrasound beams we have that return to the probe, the receiver is better able to create wonderful images for us. However, if we are misaligned with what we are scanning below the surface, we are likely to lose most of those ultrasound beams. And we are already losing quite a bit of beams for various physical reasons, including acoustic impedance. And being in line with the structures that lie below is critically important. So again, gel is very helpful in this matter, understanding the surface direction of what lies below so we can enhance our image quality. And I always say, especially when you're on the patient's chest, a little bit of added pressure at the probe. I always tell patients, please let me know if I'm hurting you in any way. But a little added pressure really does enhance the image quality. Here on this slide, we're going to discuss about echogenicity. This is a very important concept to help describe what we see on ultrasound imaging. We're going to start with the most bright object. These are hyperechoic objects. What's pictured on the screen is a coronal shot. This is taking on the side of the patient with the probe marker towards the head. The computer marker here, this is the traditional radiology view, so the computer marker is on the left. So I know the patient's head is here and the feet are here. Pictured here is this hyperechoic structure just wrapping around the liver, and this is the diaphragm. And hyperechoic structures reflect most of the sound waves and appear quite bright on imaging. We are going to compare that to an anechoic structure. And what an anechoic structure typically would be is liquids. And this would be liquids of all types. This could be pus, this could be blood, this could be urine. Anechoic means devoid of echoes. So there are no echoes that get bounced back when ultrasound beams hit liquids. In fact, they travel through until they hit something solid and then get bounced back up towards the receiver, the probe. The isoechoic liver pictured here is the most isoechoic organ of the body. So typically the liver is used as a nice anatomic structure to compare other organs to. And in a healthy liver, it is isoechoic. And we can use that to compare what's pictured here is the kidney. So this becomes extremely helpful. Obviously, if the patient has underlying liver disease, such as cirrhosis or fatty liver disease, that may change the isoechoic architecture. Here is the hepatic renal recess, and then we have the kidney, and the renal cortex on the outside appears hypoechoic, and that is the transition between anechoic and isoechoic, and that is the renal cortex. The renal pelvis, you can differentiate quite easily between the cortex and the healthy kidney, and it appears slightly brighter than the outer cortex, and that has to do with the amount of fat within the renal pelvis. So here we have a shot of a coronal abdominal image with using a curved linear ray, and we identified structures: our hyperechoic diaphragm, our isoechoic liver, our hypoechoic renal cortex, and running through the liver are our anechoic structures, which are our hepatic veins.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.